Okay, so good afternoon, and thank you for being with us today. Um, Thank you for attending this. It's the first webinar that the PRAM is hosting today. So let me first, before introducing our guest speaker today, let me introduce a little bit, say a couple of words about the PRAM and the PRAM Game Lab. So you know that PRAM, Participatory Research and Review, our goal is to foster transformative engagement of the stakeholders in the co-production and use of knowledge to improve health. And we work with different stakeholders. We work with patients, their family, with physicians, with researchers. And we are launching today this initiative that is the Game Lab. We want to take advantage of the experience that the PRAM have gathered through these years and to give a step further and to explore game-based learning and how can we use game to impact behavior and to improve behavior in health. So our approach to game learning has two characteristics. The first characteristic is that the games are co-designed between multiple stakeholders. The second characteristic of our approach to game learning is that we focus on direct care partnerships, intercultural dialogue, adaptive management, and equity-oriented research, particularly supporting the socially marginalized and those in poor, resource-poor settings. We are currently working on 3 games in the Game Lab. The first one is Game of Zones. This is a game aimed at taking Aedes aegypti and dengue and Zika in Mexico and Nicaragua. We have also cultural safety in medical education, which is my project, and we are focusing here in how can we co-design a game with medical students to train them in cultural safety. And we have also a No Game. This is a game on patient engagement that we are working on here in Canada with Anne-Marie Chomat and Alex McCammon. So the director of the Game Lab is Dr. Neil Anderson, and we have 3 co-directors at the moment, Dr. Chomat, Alex McCammon, and myself. The activities we are going to have from now on is webinars. We plan to host 3 or 4 webinars, which are spaces from which share projects and ideas, and the idea is to learn together to improve our projects. And we have also, this is an opportunity of networking and staffing to get to know people working in the field so we can improve our games and the projects. So now it's a great pleasure for me to introduce our distinguished speaker who is going to talk about technology-based approach to mental health in primary care. Dr. Manuela Ferrari, thank you for being with us. She is a research associate at the Douglas Mental Health Institute in Montreal, and she works as an Adjunct Professor at School of Health Policy at York University. She received her doctoral degree in health and behavioral sciences at the University of Toronto, and as a postdoctoral fellow at McMaster University, she worked with a video game company to help create Berries. Berries is a commercial video game aimed at overcoming mental health stigma. So thank you for being here, Manuela.
Thank you so much. Thank you for having me. And it's a pleasure to be here with you today. We have quite a ambitious agenda for today, but we're going to walk through it due to some of the slides, and other we're going to spend a little bit more time on. And luckily, there is some video and audio files that are going to make this presentation a little bit more engaging for you. So we're going to talk briefly about mental health in Canada, and most important, the possibility of integrating mental health in primary care. And I'm going to share with you my experience in working on 2 projects. Castle was actually a York University project. It was a screening for a common mental health condition in primary care setting in Toronto. And also I was able to work at McMaster University on the creation of 2 video games. One is a psychoed video game, Harry's Journey Back to Reality, and the other one is Debrief, where I work with an industry company. And luckily we will have time to discuss and share. So common mental health problems are actually a growing concern in Canada. And when I use this term, I'm referring to anxiety, depression, post-traumatic stress disorder, just to name a few. What we also know is the young people are affected. And I'm pointing in the issues related to young people because I see also an opportunity to engage them and act as soon as possible to prevent a chronic condition to develop. I will start with sharing the narrative of two people that took part of one was an individual interview. Jill is a young woman who experienced psychosis, and she was describing me her contact with primary care setting, and also the voice of the narrative of a family physician that I had the pleasure to meet when we were working on the video game that you're gonna see. So that's what Jill has to say. So I'm going to come back on those two narratives at the end. But what it seems to me the struggle, and it's often common in doing qualitative research, is to see sometimes how people who are seeking help find themselves on one side and provider healthcare setting on the other side. But I'm going to come back on this metaphor, and we can try likely to unpack and discuss this together. So I really like this image to describe primary healthcare setting because I think it captures the idea that we are talking right now because of the changes, especially in Canada, on professional teams, and there is not an attempt to help a person or a family, but I feel they're working with the community. They try to understand what are the community needs and what is the reality of that community to really try to help, again, the person and the family, and integrate these. So in integrating mental health into primary care, we actually do have there are some reasons why we should do it and also some opportunities. First, mental and physical illness are actually intertwined. We actually do have the opportunity there to promote rapid access to specialized care if actually needed for the person. And luckily, we can say that that can generate cost-effective treatment and provide the good of the people and community. And if I can add an extra point here, is also that I think we are embracing also a social justice oriented framework in really understand the need of the community and providing holistic health. And in some, I would say, area where maybe mental health is not treated with dignity because of the infrastructure of the stigma that's still attached to it, maybe primary care is the best option for people dealing with issues. So let's walk through it, my experience of working on an application. And in this application, I want to acknowledge the team that made that possible, the principal investigator, Farah Ahmad, and Access Alliance. So it's a community healthcare setting in Toronto, 3 different locations. And their mandate is actually to support immigrant refugees with a strong desire to really meet their needs where they are. So those are some of the publications that came up in relationship to the project, just to also identify that I cannot cover all the findings. I'm going to try to focus on this presentation on the experience of using this technology in primary healthcare setting, unpacking some of the provider view and some of the client experience. So what is ICAS? It's a computer assistant client assessment survey. So we like to think it's user-friendly, as actually some of the participants identify. So basically, I think everyone is familiar. It's a touch screen survey. They try to understand and assess the mental health data of clients. What is nice is that the clients are using it before seeing the primary healthcare providers. So in using ICAS, basically the client has the opportunity through a decision tree to ask some of the question, and so some section may not be applicable for the person, and other are actually quite relevant, So there is this opportunity to maximize the time, both of the clients, but also of the provider who is going to receive an output of that screening before seeing the provider. Sorry for the image. So what is actually ICAS assess for? Assess for depression, anxiety, post-traumatic stress disorder, and alcohol use using validated scale, and I'm going to show you the scale in a moment. But another thing is very key important is assessing for social determinants of health. So it's basically knowing and working with immigrants and refugees population. One of the things provider wanted is, do we know about food security? Do we know about job, stability, safety in the household, neighborhood, possible violence, especially women are facing or faced in the past. So that I think was very important. HICAS also provides, as I mentioned, a tailored output, very simple to understand for both the client and also for the provider. And when I was part of the project, the study screened in two languages, English and Spanish, because was the language that the provider want to. And now I know other languages, Chinese, Mandarin, Chinese, and I think Farsi is also available for on the application. I briefly mentioned about this, and we are going to come back also when we talk about Harry's journey, the video game. So waiting time. So there is we can kind of say quite a lot of time that a few of the clients are spending in our waiting room, and I think not just in primary care, but also in a hospital and in other settings, and say, so can we make use of this time in the best ways possible? And I like to think also we can create a fun solution for people so that we can kind of entertain them, and we come back about that with Harry's journey. So that was the model that was used to evaluate HICAS, so to run a randomized trial. And I'm kind of touched a little bit because I feel it will be not providing justice to the presentation to tell you the outcome of the trial. But really, what I said, my desire is to focus on the qualitative elements, so the experience of a clinician and provider, the follow-up case study interview that I conducted. As you can see, there were two objectives, and I'm going to come back on that. So one objective was the ability of, after using the technology, to discuss mental health during the visit, and the other one is the detection of clinical situation, mental health issues. Those are the scales that we're using. We use the short version because practically they are fast to use, and they were actually quite easy to modify for the application. So a little snapshot of the demographic, the two groups, so the group that received ICAS and the group that didn't receive ICAS before within the healthcare provider were quite similar. As you can see, I want to point to the attention of how many people describe that they actually experience violence. And again, I want to remind that those were people, recent immigrants to Canada, as immigrants or refugees. We also come back on some of the findings in the sense that this primary healthcare setting is actually quite prompt to discuss mental illness with the client or be aware about some of those issues. We have some implication for the findings of this study. And that is a kind of, I don't know, things, I don't know if people are, so the visit when HICAS were used was just a regular visit, so not in acute situation. People, both groups were there just to see the GP for a year appointment or any other situation, which I think it tell us of how can be integrated in a simple way into the setting, right? So In interviewing a clinician after the use of the application in the primary healthcare setting, we identified that there was 4 key themes, and I'm going to briefly review it. So some of the challenges in assessing mental health, the benefits actually in using the technology into the setting, but also some of the challenges. And in talking about the challenges, as you can see in this quote from a nurse practitioner, basically stigma is actually so present in the setting and made it difficult for the person who is experiencing to disclose the situation. And if I want to add something here, is also that unfortunately still in our society, sometimes mental illness is seen as something that you can get rid of on your own. It's not something that you actually should talk to or seek help for. If you're strong enough, you can get rid of. And that's something that is important to keep in mind and be aware of. So provider identified there were 2 sets of benefits for clients and benefit for themselves as a clinician. So if we go through some of the benefits for clients, there is self-awareness. So just to make it quite tangible for you, is that because during the waiting time, some of the questions were asked, the person had the time to ask, so how is my mood now? How do I feel? How is the anxiety? And sometimes we are in a busy life that we don't have time to think about it, right? And that was actually, it came up both from the clinician, but also from the person that I interviewed in the follow-up study. There is the opportunity to discuss those information during the visit, because now we have this activation, let's say, this awareness. So it's possible to open the door for discussing mental health issues. There is also the possibility, so there is what provider said, a normalized mental illness. So as much as we spend time to ask about physical illness, and it's quite a routine, sometimes we don't touch that as a topic. And I think it normalized the fact that here I can actually ask some of those questions, and some may not be applicable for me, but some actually, surprisingly, actually is true. I forgot that the loss of this person actually, maybe I move on too quickly and I'm not really over that, and it's still impacting me in some way that I don't, because maybe my energy level is not the same and my sleeping pattern is not the same. So all of the experience that people describe. So for clinician, on the other hand, it was an effective tool for screening. So the screening was already in place before them doing it, so they enjoyed that part. And found the report very useful, because the report, I don't have a copy for you, but very simply flag what may be some of the issues, right? So at least you can just ask about, seems to have difficult on sleeping. Anything that I can do about that? Just to give an example of. And in some cases, there was the identification of new cases. There were some challenges. So clearly, through, as I say, we do have the waiting time. The waiting time theory works when, and I didn't mention in this setting, people saw the GP based on appointment. But in the case of the client is late, you don't have really any waiting time. So that's created a little unbalance there. The other part, which I think is the key part, is the multiple issues, right? The person is there for other reason, and there is other priority. So now you flag something, but you don't have time to talk about it. Provider said that it's still not bad. They put it in the file, and when they see it again, they bring it up, right? But that's something that I think it's important to recognize. Sometimes, unfortunately, the system didn't work, so the clinician didn't receive the report on time. And in some cases, and I think there were some false alerts, we were able to identify that some of those cases were due to sometimes language barrier, right? Because one of, or misunderstanding of some of the questions. So we did follow up an interview, and after between 6 months to 1 year, we contacted people that use iTALs to try to see if they have a memory of what happened after, that they were exposed to that. Did the doctor talk about some issues? If there was a referral, And we thought that the use of technology over time did have an impact in some of the people that use it. And basically what was able to do was, in some cases, to detect a mental health condition that there was not, maybe it was taking longer to be detected by the clinician. In other cases, there was the possibility of identifying a comorbidity that was, in place, right? Maybe someone was already seeing someone for anxiety, but because of life change and other things, now there was some level of depression or other elements that maybe was important to discuss or be aware of. And it was also a possibility to prevent relapse in some situation. And here is, for example, the journey of Angela. In that case, it's a detection. So Angela actually identified that there was now some mild depression that was influenced. And again, I remember we talked about the idea of social determinants of health. Over time, Angela feels that she lives in an environment that's very unsafe for her and her family, and didn't realize how that had an impact in her life. And now that, that's just how she describes. So after using it, so there was a detection, the possibility to talk to the GP, and the referral to a counselor. Again, we took with the interdisciplinary team, the counselor was available in the same clinic, and so Angela is actually now starting working with the clinician there. And and I think Angela was in just for a short period of time. At the point when I met her, she was not seeing the counselor, but she knew that if she needed, she could ask again to have an appointment, which it provided fantastic security blanket. So those are some of the quantitative findings. So the good news was that the use of technology in the after analyzing the RCT was actually effective in promoting the discussion about mental health issues in the primary care setting. In the second aim, which was actually like the detection of occurrent mental health issues. So as you can see, there is a difference between the two groups. Nevertheless, after controlling, that disappears. So that we discussed, and I mentioned how this primary healthcare setting is also prompt to detect mental health issues. So maybe that's actually why some of the issues, we didn't see significant between the two groups. Also, our number, I didn't, 75, so the group was 75 people received the use of HiCast, and 75 were just seen without the use of technology. Some reflection of what to do, so or what can be a possibility, and I think people will have a different opinion. There is a potential of using technology for screening, but I think screening sometimes is this open question: should we do it? Should we not do it? And what if we screen and we don't have a structure that provides care, right? That's actually for Access Alliance, the setting where the tools was used, there was it was a positive experience because they had the structure to do that. So they were happy to know that they already were doing well, and they actually felt like we can actually use and adapt the technology and try to use this time, the waiting time, to really serve our clients better. So now, as promised, we are going to move from apps to video games. So a little snapshot about the video game market industry. Funny, because for this slide I had an old graphic from 2013, and at the point the industry was marked around $25 million, but and that was 2013, and you can see how, so in North America, it's actually on the bottom here, we're getting closer to $30 billion, but look, that's, I was surprised, I didn't have a sense of how different places actually like, it's, as I said, it's bigger than Hollywood at this point, or bigger than movies, right? And definitely we have a good production of video games in Canada, and the market is growing, as you can see from the other. Good also news is that our video game industry is also providing fantastic reports, so we do know how the market is doing. But clearly, it's here to stay and it's here to grow. So I want to acknowledge the team that actually created Harry's journey back to reality. Dr. Suzanne Archie, principal investigator at the McMaster University, and all the other organizations, they were there to support the project and as content and knowledge, but also with funding. So when we talk about video game, we probably 2 slides of content. And you can imagine this group is familiar with some of those terms. So when we mean gamification, so the application of game elements on digital design to non-game problems. And when we talk about those elements, just to review some of them, because you will see some of those elements, I hope you will see them in Harry's journey. So it's the idea of engaging the player, so this is part of fun, and but this fun is not just for the idea of fun, there is the idea of learning by doing. There is an attempt in using gamification of not working only on cognition, but also on emotion as well. Think about, I always like the difference, for people that don't play video game, reading a book, watching a movie, you cannot get connected emotionally to some if it's good book and a good movie. So video game give another option because you can actually change the reality around you. You can change the story. The power of the player is quite high in that way. And that actually creates the opportunity of the learning experience. And it's the learning by trying out and learn what works and what doesn't work. And that's where actually we can experience. And as I mentioned, we are in this setting, and that's where there is this kind of simulation, the experience of the tangible experience of doing things in this setting. So Harry, back to reality, it actually was considered a serious video game. And so where we bring this idea of a serious topic, such as health behavior and issues, into, we make it entertaining for the player. So there is this learning and knowing and approaching serious topics. So Harry's journey is actually a video game about psychosis. And just one slide to say why we wanted to create a video game about psychosis. Actually, we end up to create 2 video games, but and I'm going to tell you why about that. So first, because young people are more at risk to experience the first episode of psychosis. But also we know that they are also the ones that play video games, so it's a good tool to engage them. What we didn't realize that in the usability testing, and also in what I'm going to present to you when we show the game to family doctor, the reaction that they had, and there was actually a positive reaction. At the same time, movie television creates misleading knowledge, information, also with a stigmatizing knowledge about mental illness. And so that is to create actually a tool that can be talking back to these dominant discourses. I'm working with my team at the Douglas, and we just completed a review of game available on Steam within the last year that keyword on mental illness, psycho, doctor, psychiatry, and we try to identify what is the content, what this game are associated with. And it's quite disturbing how really the message is. It's really mental illness, insane and violent, and that's and also care, hospital things. So the adjective associated with those games is horror games. Those are horror games. I think that we can reflect that there is maybe that's not the message we want to send to young people, because when they experience it, it will be difficult for them to tell us about it. At the same time, I know that a lot of work done on video game tell us that, we need to be careful, it can create addiction, there is a lot of violence. But other research that maybe doesn't get the same attention tell us that it's a good medium to actually help and create, support the social interaction. For some people, it's a way of being social, for learning, for emotional growing in some way, dealing with some of the emotion. And I think that this will go back to the idea of learning by playing video game and this possibility of discovering these new plays. And the discovering is the self-discovery in going through the game and discovering of issues that the game actually is describing. Just to identify that Harry Back to Reality is not the only video game about mental illness. One very well studied is Park, and it's a game about depression from New Zealand, then with elements on CBT. And I would say robust evaluation of the game and quite nice outcome. So now is the moment of truth, and I'm going to show you some of the scene of Harry Back to Reality. Actually, I'm lying, because first I'm going to tell you how we came up with the game, and just a couple of slides, promise. So what you will see coming up through was the product of knowledge generation and synthesis and exchange. And I give you, and that was the work done by Quan McKenzie and Dr. Archie, and I was involved as well as a postdoc at the Center for Addiction and Mental Health, where we actually investigate some of the publication, pathway to care for people experiencing psychosis. So who did they see? What was the experience of seeing? How long did it take to see, to get referred to the specialized treatment? And we gather all of these numbers and experience and come up with, you will see in the game, kind of a pathway to specialized treatment in a journey where actually Harry can, it's a positive journey, because unfortunately, as you can see, my apology if I'm quite overwhelming, but I always say when I show this slide is try to navigate the system, think that that's actually what you have to go through it. And I'm going to walk you through it, so at least it's not going to be so complicated. So early intervention programs are like community-based intervention specialized for psychosis. So one important thing that you want to know about it is that you don't need referral. You can walk in and someone is going to see you. The Douglas early intervention program that I'm working is going to see you in 72 hours, because they know it's important. It's not easy for the person to be there. Someone should see you soon. And the family as well, right? They are part of the pathway. This is a pathway that operates in Toronto. So what you see on the other side, who is involved? And here I say, because we talk about primary care, you can see how many people, so GP for, when first experience. Jill was actually a person that I met. It was part of this study. Other people, when I say other, it may be community council services or other. So you can see some people try and can see. What happens is that the system, they start to do in a loop. People kind of wait, and after they get two, they go to emergency. Emergency, they get inpatient because now it's too severe to be, treated at home, and after outpatient, and still sometimes don't know about early intervention. Have to go around a couple of times. The other sad news here, and unfortunately, is that, as you can see, which is sometimes is not used in some pathway. In mental health and illness, you can start seeing the police involvement in criminal justice is one of the entry points. And I hope one day we are not going to see this anymore, because we don't see any other issues. So as you can see, in Harry's journey, it's actually a series of mini games. So Harry's journey is talking the story of Harry, young boy. He loves sport. He plays in a band. You're not going to see some of the scene, but he's very active. At the same time, as a young teenager, he also smokes marijuana. So Harry's journey unpack the connection from experience of psychosis to marijuana use. So what I say with a non-harm reduction, with harm reduction approach. we are dealing with young people. But at the same time, when the player experiences what Harry is going through, you also have an opportunity to learn about about psychosis, for example, about anxiety, about depression. Harry at one point, unfortunately, was having a panic attack during the party. So after playing Harry Journey, the player can play the Harry Journal. In the journal, the player can go back with the trivia, the quiz, and test his knowledge. You will see some of the things. The last element again is the pathway to care. I'm going to show you some images as well of. So pathway to care will say more app-based, interactive map of the city of Hamilton, where the player can see and find out where to receive help if needed, and what are the criteria to get there, who is working there, and the kind of help they provide. So let's try to see some scene of the game now. That's very cool. A little mini game you can find you. Especially not easy. But kids do it quite quickly. Oh, sorry. Another little mini game part of. Sorry. Our friends. People can read about. And just to give you an idea of how the game was created, the room that you see, the 3D images, they actually picture the real setting. So when young people see those images and they go to the clinic, everything looks like exactly how this was in the game, So it's not just finding out who is there, who is working, what they do, but also like you start to be familiar with the environment. Sorry if you feel very confused. Just want to give you a little idea of how the game looks like, sounds like, without giving away too, because I want you to play the game. So the next video is actually where it's actually what we call a dilemma. So during the game, the player can help Harry to ask for help. So the player can see different providers. You remember the map that I showed you? So there are community service, there is the GP, there is the intervention program. Unfortunately, in the game, the player doesn't know that there is also emergency and hospital. And basically, you can have them play and say yes or no. Do you want to see this provider or not? After that, when through the journey to see that, unfortunately, start to listen voice and there is some anxiety, you start to have some delusion, and there is a panic attack, and that's where actually like everyone is worried about Harry. So, very timing game, how we say. So I'll show you a little bit more about it so you can see how Harry see different provider. You can see how the game is psycho and educational, because you can see sometimes it takes away the flow of a video game because you have the content. But at the same time, we use it to deliver knowledge, in a different format to young people. And open the discussion, right? So that can be in place with where the game is being used. So I'm going to share with you some of what the Tamil family physician said when we actually played the game with them and tried to get some feedback. One of the things, those were some of the teams that we identified. So five family physicians working in the same clinic. So similar to what I described before, sometimes it's difficult to talk and assess mental illness in primary care. You have the first provider, a family physician, that I share the narrative, we say that doesn't feel very comfortable in talking or asking about. We have a very interesting discussion about the space of mental illness when physicians are in training, and how that can support or not the possibility of talking or discussing or feel comfortable about. Clearly, the time is always a problem. The person is there for something else now. And it's almost like the last thing that you have an opportunity to talk about it, and at the same time, if you actually find that it's not easy subject for you to discuss, maybe if no one is identified. So I'm going to share another. So we're dealing with teenagers, and teenagers they are in a place they don't want to be. So that's, but that's also because it offers an opportunity to engage young people through a different medium. That's a video game, and there is an opportunity. So let's say some of the feedback that we receive about the video game. I can say generally it was quite positive. I think that some people also realized that there were some things that they never knew about it, also like in healthcare setting in their own area. So all the physicians were from working outside Hamilton in Ontario. So and they didn't know about some of the programs that actually were in place in the area of the referral as well. So it was actually like gaining knowledge. Also like the reflection of how to ask the question and be a little bit more open, more direct question, and the interesting comments about really how that's Harry's room. You saw some other element of actually, like you see Harry, you ever seen Harry play in a band? So Harry is also doing very well in school as well. Unfortunately, because of what is happening to him, he starts to have problem in assignments and homework, right? But he's actually a very good student. So there is opportunity to relate to Harry as a player. And again, we're going back with this idea. So for them, when we ask, can you see it using your setting? They say, yeah, if there is the opportunity to connect to internet, we have, the time that they're spending there. Or like sometimes they say, like, if I already assess that there is a need, maybe in me doing the paperwork, doing the referral back or talk with the parents, they can actually spend the time and play the game. So they are aware of some of the setting if I'm referring to this team or this assessment or this other. So that was quite positive news. I think it covers most of the content here, and I really want to have some time for question and reflection. Let me see if I'm missing any. So again, even without knowing the physician, the idea of using the waiting time to help them, and they see overall as a good opportunity to actually engage young people. So I'm gonna show you. So most of the work that you saw was using engaging all different stakeholders and using participant methodology in different way. So the brief is that the commercialized video game that I mentioned. So how the brief came to life was because Dan Clark, the CEO of Moonray Studio, played Harry back to reality, and he really liked this idea of creating a serious video game. And that's where I actually, we were successful with the Mitacs Fellowship, and I spent a year working with the company, and one of my roles was actually involve youth who experience mental illness and addiction, and we met for 8 months with the industry company to think about what's going to be in the game, how the game should sounds like, look like. The idea of what you see as a surreal game is because for us was the idea to provide a mental illness with dignity. I told you about how up there are a lot of games that identify mental illness as a horror. So how about we create the experience in a game where no one can relate it to and everyone can relate it to. And we pay more attention of the people that are into the game and the emotion that was happening. So they really try to understand the experience of psychosis and experience of helping someone to seek help, but in this very surreal game. They also try to make you know, it wants to be a very good game that players that don't want to receive any information about psychosis will enjoy to play, and at the same time without knowing, also learning or reflecting about some of the issues. I'm gonna show you okay, I don't, okay, I think I did that. Oh, core? No? Sorry, no, okay.
Yeah.
Oh, yeah.
Okay.
All right, now you can see how it.
Yeah.
Okay. Okay. You can see how it's completely round and look like different. I'm actually like closing. So we start with those two narratives and this idea that they are on opposite side that we defend. I like to conclude with say that maybe we are on the same side and read some thoughts. Sorry, my eyes are not as good. So, we got it. Anyway, so you saw the final images. So the idea that maybe we have some, it's not easy to assess how to talk about the mental illness. But I like to think that maybe we are on the safe side and on the same way, we can try to find a way of working through the possibility of integrating mental illness character assessment into primary care setting, and maybe technology is a way of overcoming that. So, and not a lot of time, but
Well, thank you, Manuela, for your enlightening presentation on technology-based approach to mental health. Unfortunately, we ran out of time, but I don't know. We have like a couple of minutes. If the audience have questions or comments.
Just have a question for clarification. I mean, the last bit that we saw was that that you're actually playing the game.
It was the beginning of the commercial video game. So the last video,
right?
Yeah.
But because and that is that to experience some of the science.
Yeah. I don't want to give up with the game too much, but yes, one of the player will experience psychosis, and the other one of the player, if you do a single player version of the multiplayer version, will actually be in a position to help someone, but you don't know who will experience what is happening. Also because you can see how the environment is kind of. But at the same time, what we do, and I was working with family members, young people, if sometimes you don't know what's happening to you. So what the game tried to do is actually identify that you really don't know when it's too late it's happening, because everything seems so real.
I was fascinated by this huge gap between the engagingness of the first game, the kind of more PowerPoint type game, and the video game. It's just it's a completely different league.
So to me, that's the lesson is different when it's academics initiating and asking the industry to support. You also have a different budget versus where you have an industry they work with researcher and young people and family member and clinician to create something that they know what is their work.
I was going to ask about that. Is that the effect of having young people? Because it seems clear that in that middle one, the PowerPoint one, nobody had asked a young person what is the best way to reach somebody like you. Because they wouldn't give that.
Like Harry's journey, like the 3D game.
Yeah. Whereas it seems that in the second one, it's very plugged into the way modern gaming goes. And I mean, what's your take on that, Katie?
Yeah, I think it's a lot more, I guess, expressionistic of the emotions that come by your psychosis rather than just I'm going to the doctor. So it actually gets the player to understand a bit more of I guess the emotions.
Yeah, and I think that probably Dr. Harter will be, Suzanne will say also the budget make a difference as well.
I bet.
Now, young people were involved, and young people will say, yeah, not too bad. They try to say, no, good job, you guys old people, whatever to do something. But they actually like some of the learning, they focus on that. It's not a game for them.
That was impressive because when you're going into it, you think, oh, we kind of know what that whole cannabis thing is about. But even in a short clip like that, you say, in fact, I didn't know that you could know that stuff that easily. And so you do land up getting the information transferred.
Yeah. So that's why the surprising is the things that Harry's back to reality has more impact on family member and provider than young people.
Yeah.
Actually,
young people like the idea that we try something new to engage them.
But I think for the second game, you know, even just me watching it now, I feel anxious. You know, it's scary to be like underwater and stuck and losing everybody, and the light is weird. I think it would be hugely enlightening for the entire support system to a little bit more than Harry's
Get
journey.
into
Because
that
for me,
system.
Harry's journey, I don't really see the game in it. You know, I just see it as a very fancy IEC, you know, information, education, communication tool.
Yeah.
And it's not enough game for me. And just adding the tic-tac-toe, it doesn't make a game for me. You know? But the last one, that was just
Kind of sounds animated, yeah.
intense.
And everything there was actually decided. So like emotion, the unknown, the lost. So we talk about again, remember how to portray mental illness with dignity. So the idea was that we wanted to stay and connect through the game. Mental illness sometimes connected with situation of trauma, and that's the trauma of basically the team lost connection with the surface and the true, and there are just few people not sure who is actually there or not that was survived to this explosion. And so that was the idea of acknowledging that there is a component of trauma in the life of a person. But again, not pointing out to any trauma, specifically, and be open about that. But again, start with trauma.
Do you think it could actually worsen the well, if you suffer from such?
There is some disclosure and there is some resources. There was a bit. So that's a kind of the discussion, even with the young people. So I say that at the same time, so one hand say like if you go through it and you develop sort of self-awareness, you know how to cope. And a lot of video games they are actually are scary and intense. So the player knows enough of know how to. Those are people that are gonna use this game, right? People that really are exposed to quite strong content. And if it's too much, everyone has their own coping mechanism. But the game is also coming with possibility of understanding the breathing what it actually like, so that so that the people at the end of the game can make sense of some of the resources. Yeah.
Any questions or comments from our participants online?
No, I'm muted. Oh, okay.
No, they unmuted from their side.
I had another question. Yeah. My question was about how do you get people to play these games? Like, how do you advertise these games? Just because there's so many games out there, and how do you convince people? And were they marketed as like a game for mental health, or just like a game?
No, that's insane. So two different distribution. Very good question on. So Harry's Back to Reality at the Psycho Ed will be more tailored to settings, right? Not to
like
individuals. Exactly, so that the Canadian Mental Health Association is part of, and they will kind of try to aim in, but we see it more in settings, right? True, because of the content. So, for example, we cannot talk about school, about substance use, and so school was actually what I know. Sure, school was one of the settings, but it's a kind of difficult, unfortunately, to get through with that kind of content, which is ironic. But so that will be kind of the way. So it's going to be through the association that's support the creation of the game. And again, the idea of the game to be playing in setting where the person can ask for help. Didn't mention about the Back to Reality. So there is an ongoing RCT to evaluate, gain knowledge before and after playing the game in a community setting with the young people who are living in a shelter. And I think there are a good result on gaining knowledge on. We don't know about how much they like the game, but I do have also the qualitative interview that I have to analyze. So for debris, it's different. So industry, so the industry cannot know. So they went through, they already identified that the dissemination will be, now it's available on Steam and, advertising. What I found interesting is that in all the material, they don't talk about, we went back and forth, but basically at the end, they are not advertising as a serious video game, and there is nothing tell you that it's about psychosis. Which, when we started working with them, they thought they were going to use again similar, because it's very that's what's selling the business, the idea of the horror video game. So now I'm very happy that when you look online and you see it, it's an adventure game. They're not using the word horror, it's not connecting, it's divided as intense, it's scary, because as young people said, going up through it is actually scary. At the same time, they don't use that language. So that to me was, wow, so much. And I still don't know, I think we are going to find out that it was important not to say it's about mental illness, let the people after they play know about it, instead they advertise it. I think we are trying, the unknown territory there, and yeah, we see, we are going to find out what people think about it.
Well, it will work with the first person. Afterwards they will talk.
Oh, yeah, and there are already, yeah.
We have a question here.
Go for it.
Please.
Hi, this is Amar.
In Nigeria.
Yeah, when you say
Like yeah.
Oh.
Power cuts in northern Nigeria.
Oh no, it just went dark.
I see that.
That sounds like literally.
Okay, well that shows your global reach and some of the risks of global reach.
Oh, too bad.
Sorry, Amara, you probably can't even hear us anymore with
I
the
will
power.
be happy to answer any question also via
By email. Yeah.
Or
So we'll pass that on to
Skype again. Yeah.
That's the
Light goes out.
that's the problem of having people from northern Nigeria on your conference call.
Yeah.
In case they come back, I have another query, which I'm very fascinated by this pathway concept and how the game can short circuit, the endless circles that people get into. That was a very powerful graphic you had about that. We're very interested in this theme of participatory health systems, where obviously the agenda is to do things differently, and participatory game construction can be a very good way into that. Does your second game, I guess the third segment of your presentation, the underwater game, that also deals with pathways and quick access to care, or quick access to more appropriate care?
So there is a pathway, but it's a different pathway, as the pathway there is the pathway to how psychosis can unfold. And so in that way, so there is not such a thing as psychosis, everyone will experience in different way, and the game, so I play the game, I may get through one experience and it's gonna unfold in one way. As we play, or I play multiple times, I will experience in different way. And that's another way of how what we like to think psychosis with dignity, because you realize that can change. It's not such a one experience, but it is a multiple. So that game, because of the capacity of the game, the game can support the possibility of creating all of those.
Right.
Yeah.
So you're basically using an escape dynamic and using the pathways as the routes to escape. Interesting. So you've got different intervention points.
Yeah, because in that case, again, their decision, right? And in some way, there was the desire of being really different games in some way.
Yeah.
So in the game, so in the idea of, so what I think they really try to capture is when you have a person and a family member, friends, relative, and it happened to the two of them, and now you have to try to navigate the system, right? And that's what you try to do. When Harry is, you are helping Harry to make good, right? And I think in Harry's region, the idea was to be more sophisticated in the pathway. And again, I'm gonna blame it on money all the time.
Okay, so Banshee's back online.
Yeah.
We're back online.
Thank you.
Sorry, the NEPA just flaked out just at the moment when we wanted to get the answer to the question.
Yeah,
but we're on the now. So
So what was the question? Because
Yeah, we wanted to ask, when we say big budget, how much is that?
So yeah, so the Breeze, the company received $1 million budget. Not less better from other game on the market, but that's yeah, Harry's Journey.
no, Harry's Journey is a PowerPoint.
It was like, but Harry's Journey, but you need to appreciate Harry's Journey was like 25 to start with one, 25 again, and 50 and 75 for an evaluation. Because it's not easy to sell the idea of a video game.
Yeah.
Let's say you have to see a child.
But everybody is going to ask about the return and how you get that back. But I think the pathway is how you get it back.
Yeah.
Because just in illustrating the care saved and the suffering saved, that's where you get the money back. So you do need, though, to be discussing with somebody who's got a vision of the thing, because
definitely, but it doesn't go up to the normal structure, unfortunately.
it's not set up for it. But I guess this is something that we're absolutely dealing with right now, is how we shift it.
And I would say $1 million excluding the marketing. The marketing, I think, they receive extra part of the,
do you know anything about the cost recovery through the commercialization?
I think we're going to find out because it just came to them on the market in October.
Okay.
So we're going to find out.
So it's right now.
Yeah, it's really everything.
Oh my goodness.
We
So
are
we're right.
we're going to see explain, we're going to see, funny, and there are 2 video games. There's another one about psychosis that came out a few months ago as well. We talk about like for that game, it's a AAA game, so we talk about I don't know how much cost that game. It's not comparable with the Breeze, and so it would be interesting to see what is happening now that those 2 games are out, right? And
From what you know, you're much more inserted into the serious game world than we are. We're just getting into it. But where would these games stack up in the overall spread of serious games that you know about? Would you consider them in the higher end of them, or are they just like every other one that you know?
I think they are in the high end.
Because it's that second one seemed to be.
Yeah. Like I show you, like the park, there is other few video games, but any video game and that will not reach that they did have the beauty, I would say, the aesthetic and story. Everything is coming together. That it's a symphony. I don't know how to describe it.
It's
right. But again, you are the expert that been trained, have been working, and they know, and they use all the tools that they have to do that. And sometimes I think the learning is how is academic. So to me, is the question that engaging is, but how can we don't be perpetuating problematic discourses? How we want to safety? I have this idea. Okay, what if it's too much for the player? What if in the multiplayer you have someone very nice going to psychosis and the other player is going to be really a very mean person? We should prevent that. Sorry, academic try to control everything. But no, and after you have these discussions, you cannot do that, and that's because people want to play game, and people are need trust.
They need to be at the edge to play the game.
Yeah. So we have very interesting. I think we learn from
But I really think that this is the future. Like my son will start secondary school next year, and he will get game learning as a course in school.
Wow.
So the future will be different.
Yeah, absolutely. But again, how do we get healthcare to get that?
It's we have to think differently, be less siloed.
Yeah. But
Okay, so thank you again, Manuela, for being with us. Thank you to all our attendees. We will be in touch to inform you about the next webinar.
Great.
Okay, thank you very much.
Thanks so much, Manuela. That was excellent. Eye opener. Makes us look very small town.
Bye, Anne. Bye, Mar.
Thank you
Bye,
for joining
everyone.
us.
Thanks for
Bye.
joining. Thank you.